So one of the things that I would like to, for you guys to read, this was written by my mentor, by Dr. Blankstein, Dr. Gulati. This is the chest pain guidelines, right? So whenever we have patient with no known CAD, okay, so patients with PCI, you're gonna do like functional testing and everything, but this patient with no known CAD coming with stable chest pain, not STEMI, not unSTEMI, okay? So stable chest pain, no known CAD, intermediate to high risk, this is where like CT is like class 1, and you can also do like functional testing, depending upon like where you're gonna go, right? And if the CTA, if it's like non-obstructive, like less than 50% stenosis, like less than 40% stenosis, that's usually not, the pain is probably not related to cardiac. But if it's between like 40 and 90%, that's when you have a class 2A for FFRCT. And then from there, you can see if it's positive or not, and you can go to invasive coronary angiography, right? Why, we're using more CTs now, and what's the benefit? This is, from Dr. Leslie Shaw, who was also one of my mentors when I was a resident, here, a fellow here. So patients, this is from the data, from a national data registry, patients undergoing cath, about 60%, they have non-obstructive CAD. It's a lot of negative caths. And caths, again, they have risks, patients can get contrast-induced nephropathy, they can get stroke, they can have a lot of, issues, right? So that's a problem, so we need to cath, people, that we know that they're gonna benefit from PCI. So the other thing is that in the 90s, the nuclear scans that we did, about 30%, were positive. Now, with treatments and everything, just about 5% have ischemia, okay? And so the CTA ended up, being a very important testing, for those patients with no known coronary disease, because you can see how much plaque they have, and the plaque is very prognostic. And it's something that if you see, you can treat with more intensive statins and whatnot and prevent, a future heart attack and stroke and so forth. Also, if a patient has a coronary CTA with no plaque, no stenosis, if it's a CAD-RED 0, that's insurance for at least 5-10 years. And Dr. Carr was one of the people that came up, with that from the cardio study and the MESA. But having like a CAD-RED 0, it's true low risk. If you have a negative stress echo, the patient might still have a 50% obstruction over there. It's not going to be hemodynamically significant, but if it's a soft plaque, you miss an opportunity, to do high-intensity statins on this patient, right? And that's one of the main benefits, from coronary CTA. You see plaque, you treat it, okay? Not going to go into, but these are like very important trials, Scott Hart and Promise. Promise, that's Dr. Penn Douglas, here at Duke, 10,000 patients. And they pretty much show that in Scott Hart, these are like, two very important trials, showing that CT actually decreases cardiovascular outcomes, So actually there's some real impact, these patients. Part of that, is because, they have plaque, and now we're gonna have more blood pressure control, better statins, and so forth, okay? It's very important for you to understand the limitations. So patients with calcium score of 10,000, I've seen, small stents less than 3 millimeters, okay? Very morbidly obese, people, they are gonna have terrible studies, So then you're gonna try something else. You can try PAT. PAT is great. I mean, I do all modalities, so I'm not biased towards any modalities. So anything that I'll be reading. So PAT is great. PAT is amazing, but especially like in these patients, high BMIs, patients with stents, patients with bypass grafts, patch is great. You know, a stress MRI, especially with quantitative perfusion, we're increasingly doing this. It's still like a little experimental, but we do, you know, at Vanderbilt, and it's amazing. You know, it's amazing. You need quantitative perfusion, you know, in these cases. Okay, so as we talked about, you know, some additional testing, you know, FFRCT for 40-90%, it's going to be tested on your boards. You know, you be sure there's going to be a few questions there on this.